I'm starting the recording now for the regenerative medicine billing opportunities, and I want to welcome all of you here today. My name is Lisa Majeski. I'm the president and owner of Gold Star Medical Business Services, and I'm very pleased to be here today with you. I have been getting a lot of questions about regenerative medicine billing opportunities. For those of you who are new to regenerative medicine, as you know, most of the regenerative medicine services in the United States right now are considered to be experimental. They're not FDA approved, and therefore many regenerative medicine clinics only offer regenerative medicine as a cash-based service. But there have been, over the last year or so, some opportunities for providers who are offering regenerative medicine services to actually be able to bill the insurance company for these services. So this is what we're going to talk about today. Let me just go ahead and get my slide. Here we go. Okay, so here are our discussion points for today. We're going to talk a little bit just about regenerative medicine and regenerative medicine products. We'll talk about the reasons why some products are now approved for insurance billing. We'll talk about the uses and indications for billing these regenerative medicine products. We'll talk about the CPT and HCPCS codes that you would need to use. And we'll give you a taste of some of the reimbursements that you might expect if you do this correctly. And then we're going to talk about the all-important documentation requirements in order to get paid for these regenerative medicine services by the insurance company, and we'll discuss prior authorization as well. So we're going to cover all of these topics. Obviously, as with all of the webinars, if any of you have ever seen me do a webinar, we go at a very fast clip. So there is in your Zoom meeting menu, there is a place for you to raise your hand and type in a question into the chat box or into the Q&A section. Please feel free to do that as questions come up. I'm going to do everything I can to answer any questions that come up in the chat box or in the Q&A at the end of the presentation. And if for some reason we go all the way to the hour-and-a-half point on this webinar and I don't have time to answer the questions, be sure to give me your email address and I will be happy to answer those questions to you individually on a case-by-case basis. So let's just get into what regenerative medicine is. There may be some people that are listening to this webinar that don't really know a lot about regenerative medicine. So the American Association of Blood Banks defines regenerative medicine like this. Regenerative medicine is the process of replacing or regenerating human cells, tissues, or organs to restore or establish normal function. This field holds the promise of regenerating damaged tissues and organs in the body by replacing damaged tissue or stimulating the body's own repair mechanisms to heal tissues or organs. Regenerative medicine also may enable scientists to grow tissues and organs in the laboratory and safely implant them when the body is unable to heal itself. And so regenerative medicine has a lot of different applications. There is a lot of promising research in the regenerative medicine field, and there has been enough regenerative medicine done that we know that it works, that regenerative medicine is an effective way to help the body heal itself. And so what we want to talk about now are the types of regenerative medicine products that are out there. Regenerative medicine includes a lot of different types of products, as well as the delivery methods, meaning the procedures and the protocols for delivering these regenerative medicine services to a patient. Products can come directly from the patient's own body. These are called autologous cells or autologous stem cells. Products can also be derived from harvesting or transplantation, which is known as allogenic. So those are the two main types of regenerative medicine products. You have the autologous products and the allogenic products. Many of these products are available right now as tissue grafts because most of the regenerative medicine that is approved right now is for wound care, meaning for patients who are burn patients, for example, patients who have diabetic ulcers or pressure ulcers, and they need to have those ulcers repaired. They haven't had any success with traditional medications and antibiotics to repair these wounds, and so these regenerative medicine products are used as grafts to graft over the dead skin or the open wound, and then regenerate that skin into live skin that covers that wound. Some products are available as injectables, and most of the products that you see in regenerative medicine right now are only available as tissue grafts. But what we're going to be talking about today, when we're talking about some of the regenerative medicine that we can do in a provider's office, it will involve the injectable products. So what are some examples of regenerative medicine products? And please, if I don't pronounce these correctly, don't hold it against me, but we have the mesenchymal stem cells, which include adipose-derived adult cells, Wharton's jelly, which comes from umbilical cord, bone marrow, and pre-adipocytes. We also have amniotic fluid allografts, which come from the human amniotic membrane or amniotic fluid. And then we have something called PRP, platelet-rich plasma, which is a type of blood cell that aids in coagulation and contains protein to aid in healing. This comes directly from a patient's blood. It's the plasma, they're the plasma cells that come directly from the patient's blood. So in order for a regenerative medicine product to be covered by an insurance company, number one is it has to be either FDA registered, cleared, or approved. Now, the FDA regulations governing human tissue products are found in the Code of Federal Regulations in Part 1271 under human cells, tissues, cellular, and tissue-based products. So if you want to get really deep into this, into what products are covered and what products are not covered, then you can go to the FDA regulations, to the Code of Federal Regulations, and look for Part 1271, and it will give you links to all the products that are FDA approved for regenerative medicine services. And one of the things that you'll see when you look at these products and look at the companies that produce these products is that the majority of these are graft products. The product also has to be issued a recognized billing code. So for those of you who are listening to this and you're a biller, you know that we can't bill out services unless we have a code to bill. And so we need to have either a CPT code or a HCPCS code to be able to bill out to the insurance company and to place on a claim form in order for reimbursement to be considered. Now, under CPT and under HCPCS, there are non-specified codes, but generally those codes are not going to be covered, or if they are covered, then additional information has to be submitted. So so many of the regenerative products that are out there do not have a CPT or a HCPCS code assigned to them. If they do, then they could be considered for billing under certain circumstances and for certain types of conditions. So right now, the only stem cell products that are FDA approved, and remember, we talked about FDA registered, FDA cleared, and FDA approved. FDA approved products for use in the United States consist of blood-forming stem cells called hematopoietic progenitor cells derived from cord blood. These products are approved for limited use in patients with disorders that affect the body system that is involved in the production of blood, called the hematopoietic system. These FDA-approved products are listed on the FDA website, and bone marrow products are also used for these treatments, but generally the bone marrow products are not regulated by the FDA for this kind of use. So when we talk about FDA approved, we talk about this is a fully cleared and approved product for use in medical services. And as we discussed, most of this is going to be used for wound care or for regeneration of skin for burn patients and things like that. Now, there are product derivatives that are registered with the FDA, not approved, but registered with the FDA, and have been issued CPT or HCPCS codes. And these are products that are amniotic membrane and fluid products derived from placental tissue that have been donated by healthy mothers at the time of delivery by C-section. So it's very, very specific, and it's a very, very narrow type of product that is registered with the FDA. These products contain a rich amount of basic components that are needed for tissue generation, including hyaluronic acid, collagen, cytokines, fibrinogen, messenger RNA, and growth factors. And so it is some of these products that we're going to be looking at today that we are now seeing insurance companies are beginning to cover some of these products on a very limited basis and under a very narrow scope of medical necessity. We're going to be talking about what that scope is throughout the presentation today. Now, you need to understand that anything that is approved for billing to an insurance company must have the ultimate effect of filling, covering, or protecting a void or a defect in the patient's body. There's no specifically defined or published indicated use for these products, and what we're finding is that they're instead covered based on the medical necessity established by the physician through exam and testing and supported by the patient's medical record. So an indicated product doesn't mean that it's approved. It's registered with the FDA, and it may be indicated for use in certain conditions, but it does not mean it's FDA approved. So what that means is when a product is not FDA approved, the insurance company does not have a medical policy guideline for that. Medicare does not have an LCD or an LCA for that type of a product for the indications that we may be talking about. And so what that means is that these injections and these procedures are covered on a patient-by-patient basis, which is something that's like, you know, it really is one of those things that is, for me as a biller, when I first started really delving into this, that was very hard for me to understand. I'm like, wait, I need to see the medical policy. I need to know what the policy says so that I can follow that policy and I can make sure that my provider's documentation is justifying medical necessity for that policy, and I'm using the right CPT codes, and I'm billing this. So this leaves us without a medical policy or an LCD for these types of procedures. It leaves us as billers in a fairly uncomfortable position, in a position that we're not used to being in. But there are some very good guidelines that will help you understand, you know, the times and the indicated opportunities that you may have to be able to bill out some of these services. So remember that when we're going to be, what we're going to be talking about today is going to be on a patient-by-patient basis. So if you ask me the question, well, does Blue Cross cover this? Or does Medicare cover this? Or does United Healthcare cover this? My answer is going to be, it depends on the patient. There's not going to be any type of blanket coverage that we can find in which these services may be covered by one insurance company or another. So what are some of the common uses of these amniotic products now that are registered with the FDA but are not fully approved? These are considered experimental by most payers, but on a patient-by-patient basis, there may be payment opportunities available for that. And these would be conditions like osteoarthritis of the knees, shoulders, ankles, and so on, rotator cuff tears, tendinitis, epicondylitis, plantar fasciitis, major ligament tears like ACL, MCL, and meniscal tears, and spinal conditions such as facet arthrosis or herniated discs. And so for those of us who are listening in, you know, one of the reasons why I'm doing this webinar is that we have a lot of regenerative medicine practices that we do billing for, and they're hearing about these procedures that are now covered for these types of orthopedic applications, and are wanting to know more about it. And so rather than have our clients just start jumping into billing out these procedures or having us bill them out for the client, we need to make sure that you have full disclosure as to what this all is going to entail if this is something you're going to want to do. So what are some of the common billing codes that we would see in these injection procedures of these amniotic products? Number one would be, for example, if we're doing injections of these products into joints, you know, we'd have the 206 codes, and I just showed the 20610 and the 20611 because these represent injections into large joints such as knees and shoulders and hips. Now, if we're going to do the product injection into a smaller joint like a wrist, then it's a different billing code, but we can help you out with those billing codes, or if we're doing the billing for you, we'll definitely know which codes to use for the administration of these injections. There are also codes for guidance. Now, most of the regen medicine clinics that I work with personally, or our company works with personally, don't use fluoroscopy in their office. They use ultrasound guidance. Ultrasound guidance, what I have seen in some of the trials of injections that we build out for some of our clients, is that the payers, because this is such a very, very targeted injection, that some payers will not cover these injections unless fluoroscopy guidance is used. Some will cover it with ultrasound guidance. And so that's why it's very important to get pre-certs on these procedures by the insurance company in order to know whether the ultrasound guidance would be approved for coverage or not, and thus it would let us know which CPT code to use. And we're going to talk about pre-cert much later on in the presentation. And then, of course, you have the billing code for the injectable product itself. So some of the products that have CPT or HCPCS codes that we're going to look at in this particular presentation, there are quite a few of them, but the few that we're going to look at today is the PRP code, the protein-rich plasma. And actually, this is not a code for the protein-rich plasma itself, but for the entire procedure of injecting PRP into any site with imaging guidance, including the harvesting and preparation when performed. So this is like an all-inclusive procedure. Now, you need to understand that this CPT code 0232T, as in Tango, is a Category 3 CPT code. This is in the classification of temporary codes for emerging technology. So what this means is that PRP injections have not been approved as a Class 1 CPT code, meaning that it is widely payable by all insurance companies, by Medicare, and there are payer guidelines for this. So usually when there is a Category 1 CPT code, which are the ones that we're used to seeing, those are 5 numeric digits, like, you know, 99213, which is an outpatient office visit. Now those codes are Category 1 CPT codes, and insurance companies and Medicare and Medicaid plans will have payer guidance for the use of these codes. Well, with these emerging technology codes, there isn't payer guidance, not at the payer side of things. So basically, these are to be utilized on a case-by-case basis. So they're covered on a patient-by-patient case by some payers, and these are commercial payers. We do see that PRP injections are covered more frequently under personal injury claims by auto MedPay policies. And we do know that they are covered under federal workmen's compensation for a limited number of conditions as well. And they are covered, and PRP is covered by Medicare, but only for the diagnosis of chronic non-healing diabetic pressure ulcers or venous wounds. And so again, there's limited coverage. For the most part, PRP injections are going to be done if you are listening to this in your regenerative medicine practice. You know, you have probably been instructed that PRP injections are usually a cash service. You charge cash to the patient for these PRP injections. And for the most part, that is still going to be correct. However, there are these limited instances in which we can be billing PRP injections. So if you do a lot of personal injury, you know, we could be looking at billing PRP injections under personal injury plans. If you are a provider with federal work comp, and you may, after seeing some of these reimbursements that you could get for PRP on the following slides, you may want to consider signing up as an approved workman's compensation provider for federal work comp. It's a federal credentialing that you need to get. And so, for example, if you have I'm going to change the slide here so you can see what the reimbursement opportunity is for a federal work comp claim. This is a PRP injection, $1,179 for a PRP injection under federal work comp was the reimbursement that that we see on this particular EOB. Now, that's a pretty good reimbursement. So if you live in a community in which you have a lot of federal employees, for example, a federal prison, federal, any type of a federal judicial building, you're in Washington, D.C. area, anything like that, you probably do want to be, and you do regenerative medicine, you probably are going to want to enroll to be a federal work comp provider, because these are some opportunities for you to be able to bill out PRP injections to an insurance plan. Another product that has a HCPCS code, there's two of them here that I'm going to show you, and we're going to pretty much focus on the first one. These are found in the HCPCS code book, and so you have basically, kind of coding 101, you have two code books to represent procedures, supplies, and drugs. You have the CPT code book that represents billing codes for procedures, laboratory, radiology, medical services, exams, consultations, et cetera, et cetera. Then you have the HCPCS code book, which is a code book that represents supplies like durable medical equipment, injectable supplies, home medical equipment supplies, etc., as well as drugs, Part B drugs, which are not the drugs that you get at a pharmacy. That's Part D, but these are drugs that are used in medical procedures, like IV drugs, and drugs that are injected either intramuscularly, like Depomedrol and things like that, penicillin. Those drugs are going to be found in the HCPCS code book. And so the code for Palingen Pro Matrix is Q4174, and another one is called Flower Amino Flow, and that one is Q4177. Now, there are a few others in these, and this is in the found in the HCPCS code book under skin substitutions categories, Q4100 through Q4226. So obviously there are a lot of Q codes that represent skin substitution products. However, what you'll notice is that when you go to the HCPCS code book, most of these codes are graft products. And so we talked about how most of the products that are approved for billing are approved for wound care and for care with burns and so on and so forth. And so most of them have been developed as grafts. So if you see a per square centimeter as part of the product description, you know that you're looking at a tissue graft product, not an injectable. Now, some are sold as particulates, like in flakes, so for example, Q4168, amino band 1 milligram. These are sold as little particulates. And Medicare and most private payer guidelines will address these products with LCDs or payer guidelines, but only for use in wound care. There's very little literature of these products for treatment of these spinal orthopedic conditions that we're talking about in the regenerative medicine practices that we deal with, such as the osteoarthritis, the rotator cuff tears, the spinal conditions. So what that means is that it is up to the provider to establish a narrative in the patient's chart that would prompt approval and payment of these procedures. It doesn't mean that they'll never be paid, but it does mean that you would have to prove medical necessity for these products on a case-by-case basis. So, you know, some of the things that we're seeing as far as payers that are favorable to some of these injectable products for orthopedic use are Medicare, TRICARE, United Healthcare, and a lot of the Blue Cross plans. Payers that are kind of neutral, Humana and Aetna, and in general, we're seeing Cigna as unfavorable in billing out. So Cigna, many times when you submit for pre-certification, they're going to just flat out deny for pre-cert, whereas some of these other payers, you may get approved if you pre-cert these procedures. So let's give you an example of what some of the cost of these products are. And so, you know, you can see that the Palingen InnovaFlow product is, and there are several different categories based on the number of cc's that you're going to be injecting. You're going to have a different price point for these products. So you can obviously see that, you know, these products don't come cheap. And that's one of the reasons why it's so very important to pre-certify your procedure before you order the product and use it, because if, you know, once you've billed it out, if it's denied and you cannot appeal it and prove medical necessity, then you're out that money, or you're going to have to make the patient responsible for the cost of these products. So because there's no there's no payer guideline for most of these procedures and these products, there's really no published allowable fee schedule. But what we have seen some of these estimates to be is that for Medicare, because you are basically the guidelines for the maximum utilization of these as injected. For example, if you're going to inject Palingen into the knees, would be 8 units per encounter date of service, which is 2 milliliters. So if we go back to the cc's as they relate to the milliliters, it's going to be each unit is going to consist of 0.25 cc's. And so if we come back here to the 0.25 cc's and you're billing 8 units at $750 each, you know, you can see that's going to be quite high. So your fee schedules per 2 milliliters are going to be, for Medicare, about $3,000 is the usual and customary reimbursement for Medicare. For commercial plans, it can be as high as $4,400 to $9,600 per injection. And so your utilization guidelines are, we don't recommend that you perform bilateral procedures, because if it exceeds that quantity of the 8 units per encounter date of service, then you're going to have to write that off, and or you're going to have to make the patient responsible, depending on how you have done advance notification to the patient on these procedures. The Novitas coverage area, I'm in Texas, so You know, we've looked at billing out to Novitas, and they cap their reimbursement for Medicare cases between 6 to 15% over the invoiced amount paid by the facility for the product utilized. Commercial plans do not have a fee schedule capitation at this time. So let's take a look at some of the adjudication samples. This is Blue Cross Blue Shield. This is a reimbursement that was from Blue Cross Blue Shield, and you'll see that the joint injection was for the left knee, and the joint injection was billed out at $145. Blue Cross allowed $114.31 with a 90% coinsurance. The patient, it was a 90-10 plan, so you see the patient had a $11.43 coinsurance on this. The provider was paid $102.88 with a $30.69 write-off. For the injectable, for the Palingen, $9,600 was billed and $9,600 was allowed. So the full allowance was made. The patient had a $40 copay, and so the provider was paid $9,560 by Blue Cross for this Palingen injection into the patient's left knee. And so the total reimbursement was $9,662.88, with the patient's out-of-pocket cost being $51.43 with a $30.69 write-off. That's pretty significant. And this is the kind of stuff that gets the provider super excited, right? Because you're looking at this, you're like, holy cow, how can we do this? How can we be billing these injections of Palingen or some of these other injectable products and get paid this kind of money for one injection? For Medicare, the reimbursements are significantly lower, obviously. The maximum allowable that you could charge on Palingen is $3,000. Medicare allows about half of that. So the reimbursement for Medicare is $1,416.45. Your cost on the Palingen is $750. So you know you're still making a significant profit on these reimbursements. So that's going to be Medicare. Your commercial payers, as you can see, have significantly higher reimbursements. If you do ever decide to use fluoroscopy guidance, nowadays, of course, there are units that are handheld. Fluoroscopy guidance actually provides a portable X-ray where you can actually see movement in the patient. The approximate cost of a fluoroscope is fairly significant, about $20,000 to $40,000. But your reimbursements, if you add fluoroscopy guidance to your procedures, you're looking at about an additional $150 to $300 in reimbursements using fluoroscopy guidance. And be aware that when you have fluoroscopy in your office, it does open you up for other types of procedures. Like if you're doing a lot of orthopedic injections, you could do sacroiliac joint injections, because the sacroiliac joint injections include fluoroscopy or CT guidance. If you do a sacroiliac joint injection and you don't have fluoroscopy, then you have to downcode it to a trigger point injection code. Sacroiliac joint injections have significantly higher reimbursement rates. And then of course, you have that fluoroscopy guidance because you have the fluoroscopy guidance. And so, it's a business decision for every provider. It really depends on how intensely you're going to be doing these types of injections. You can use fluoroscopy for other types of injections as well. So it's not just limited to, your joint injections. Fluoroscopy has a number of different applications that can be used in in an orthopedic-based medical clinic. So it's something to consider. I've done a little bit of research into used fluoroscopes. And you can check with a local X-ray distributor in your area to see if they have a line on used fluoroscopes, aftermarket, or gently used products. You can usually get those for about half the cost of a brand new one. And usually if you purchase them through a a distributor, a local X-ray distributor, they will do all of the service and maintenance and get them certified for use, so that they are, they're safe to use in your clinical setting. Now, if you typically, I know that I talked about Palingen and I talked about InnovaFlow and Flower Matrix. These are based on certain manufacturers' products, and so these codes are assigned based on the product that is made by a certain manufacturer. So if you typically purchase your product, your regenerative medicine product, from another manufacturer or distributor, you're going to have to check with them to see if their product has been granted a HCPCS Q code. If it has, and there is an injectable product with a Q code from the company that you purchase your products from, then you could use that Q code for your injections, as long as these companies work with Medicare, they work with the commercial payers to ensure that on a case-by-case basis they would be covered. And so, but if you're using a product that is not from Palingen, that is not distributed, then you're going to have to probably choose one that does have an approved Q code from an approved manufacturer. Wrong way. So let's talk about some patients who might qualify for these kinds of injections and these types of reimbursements. I'm going to use a knee case because knee cases are fairly common in the regenerative medicine practices. A lot of regenerative medicine practices are already doing the viscosupplementation therapy, the hyaluronic acid injections. You're already doing some bracing with your knees. You're already providing physical therapy for patients who have osteoarthritis of the knees or who have post-surgical knee conditions. So patients, in order to qualify, first of all, for one of these types of amniotic product injections, there has to be a progression within that patient's care that would make these injections medically necessary. Okay, so the first thing that you have to know is that if you're thinking about a patient and you're thinking about offering this injection to the patient, you must have documented that the patient has first tried and failed conservative therapy lasting 90 days or longer. So, unless, this isn't really going to be for a new patient unless this new patient is transferring somewhere and they've had 90 days of conservative therapy. If they're a brand new patient, you're going to have to go through that conservative therapy first for at least 90 days before you can even consider doing these injections on that patient. So the conservative therapy, it consists of a course of oral NSAIDs, if not otherwise contraindicated, meaning that they don't have adverse reactions to that, and at least one of the following 7 bullet points: physical therapy, bracing, DME, viscosupplementation therapy, corticosteroid injections, topical analgesics, attempted weight loss, and home remedies. Now, you may be thinking, oh, well, yeah, I've got a patient who's coming to me, a new patient, and they say, well, I've been taking, ibuprofen for at least 90 days, and I've been doing all kinds of home remedies. I've been putting, capsaicin on my knees and it's not working. Would they qualify? Theoretically, they would, but remember, you're making a case on a case-by-case basis. And so one of the first 3, physical therapy, bracing, and viscosupplementation therapy, are going to make a stronger case for medical necessity than the other 4. So just kind of be aware of that. And, you know, corticosteroid injections, yes, that would probably qualify, but most of the regen medicine clinics that we work with don't do corticosteroid injections. And so that's kind of off the table unless they've had that at another medical facility. So because there are no medical policy documents or LCDs for the amniotic allograft injections to treat orthopedic conditions, it will be up to the provider to make the case for approval of treatment in the patient medical record. Let me tell you something, every single claim is audited, okay? On these types of injections, you cannot send those injections in and pray that you're not going to get audited. Every single claim is going to be audited. Now, the question is whether it's going to be audited pre-procedure or post-procedure, okay? So it is my recommendation and my strong recommendation that if at all possible, that every claim be submitted for pre-cert or pre-approval, okay? Because here's the thing, if the claim is pre-certed in advance, if you send your documentation of medical necessity, your letters of medical necessity into the payer reviews the chart, they review the reasons why you want to do this therapy on a patient, and they say, yes, it's approved, you will bill it, and they may never come back and take that money back. So you would never be subject to a post-payment audit. Now think about that. You get a $9,000 reimbursement and you have not been pre-approved. Now the insurance company comes back and audits you, and they most certainly will, and they want that money back. Well, that's not good. Or you do the injection and the insurance company pens the claim and denies it, and now you're out the cost of that injectable material. So before you spend any money on this injectable, on the amniotic allograft products, you want to make sure that you are that you are getting these claims pre-approved. Now, federal payers, Medicare, won't do pre-certs, which means that you have a little bit of a risk when you are submitting to Medicare. However, what we found is that if you follow the guidelines for establishing medical necessity and your documentation is bulletproof in establishing medical necessity, most of the time these will get approved. You'll submit the claim, Medicare will pen it for documentation, and you will get those claims approved. But you have to make sure that your documentation is absolutely bulletproof. And so my recommendation is going to be for the commercial payers that if at all possible, these procedures are pre-certed or pre-approved. And for Medicare, we just make sure that you have somebody look at your documentation and look at all of the documentation you have who knows what they're doing to help you determine whether your documentation is good enough to be upheld in a concurrent audit with Medicare, or in a post-payment audit for that matter. So what are some of the essential elements of documentation that you need to have in your chart to prove medical necessity? And remember, this is a case-by-case, patient-by-patient basis. So, of course, one of the first things you want to do is in the patient history, you must notate that the patient has undergone at least 90 days of conservative traditional treatment, okay? And we talked about what those traditional treatments were in an earlier slide. This might include physical therapy, viscosupplementation, compression and bracing, medication management. Maybe the patient comes to you and they used opioids to treat their pain. And they don't want to do that anymore, or they used opioids, they became addicted to opioids, and now they absolutely don't want to do anything in which they're going to have to take opioid drugs, but they're experiencing significant knee pain. Make sure you document everything that the patient has tried and for how long and when that therapy took place, okay? So don't just say, Patient had 90 days of physical therapy. That's not going to be enough in the documentation to prove medical necessity. You would want to be much more specific than that. Patient received physical therapy from such and such a time to such and such a time. Physical therapy consisted of what types of physical therapy exercises did the patient do? The more detailed you can be, the more likely it's going to be that your procedure is approved for billing, under a pre-cert. And more likely that it is not going to be denied upon a concurrent or a retrospective audit by Medicare. So make sure you are as absolutely specific as possible. Now, if the patient comes to you and they had treatment done somewhere other than your practice, make note of what, when, where was the treatment done, what treatment, when was it done, where was it done, and request records from that other facility. I would not send in an incomplete chart. I would want you to, if at all possible, get those records from wherever the patient was treated and put together a good comprehensive case on to be able to present to the insurance company for approval of these charges. And guys, it sounds like a lot. It's like, wow, that's a lot of stuff that we have to do. Well, yeah, I mean, if you're going to get paid $9,000, you need to make sure that you're giving the insurance company $9,000 worth of reasons to approve those services, okay? And so that is some of the essential elements of the documentation. Now, patients who you have in the office who are currently under conservative treatment, one of the things that you'll want to do is update or revise their treatment plan to help aid you in the transition from a failed visco case or failed physical therapy or failed bracing into an amniotic allograft injection. So your treatment plans, as you're writing your treatment plans for your patient, if you're keeping it in the back of your mind that this patient may eventually have this amniotic allograft injection, you would want to add something to your treatment plan under the treatment goals that says something like, if the physical therapy series fails to provide complete relief of symptoms and return to normal function, and to avoid use or regression back to opioids or knee replacement surgery, patient will be advised to consider an injection of amniotic allograft tissue to reduce local inflammation, provide cellular scaffolding, and to fill local tissue void. Remember, those are the only reasons why these would be considered for payment, okay? Reduce inflammation, provide cellular scaffolding, meaning wound care, and to fill a local tissue void. So make sure you are setting up your treatment plans correctly to prepare the insurance company for the possibility that this may be done, okay? A couple of other things that I would, and you may need to change your intake forms to include some of this, but I would really explore the opioid track with the patient. I know that there's, a lot of people will have in their intake forms, are you a current or former drug user? And some patients hesitate to answer that, or they may not give you the correct answer, but it's actually really important, because if the patient is a recovering opioid user, okay, or a recovering drug addict, and they want to do everything they possibly can to avoid knee replacement surgery, because if they have knee replacement surgery, they are probably going to have some type of morphine or pain medicine post-surgery, and they don't want that. That is a very strong case for these allograft injections, okay? And so you really want to, and sometimes you have to be very sensitive with the patient and say, look, especially if the patient has knee issues, or it looks like they may end up having to have hip replacement surgery or shoulder replacement surgery or knee replacement surgery, is really try to get them to open up, and be honest about opioid use, because this is a key element in establishing medical necessity to prevent the patient from having to have knee replacement or shoulder replacement or hip replacement surgery. So think about that. The other thing you want to be documenting in the patient's medical record is their history of falls and whether they are at risk for falling. So patients who, have very, very, bad knees, patients who have severe osteoarthritis of their knees and are at significant risk for falling, or who have fallen in the past, and as a result of past falls, if they fall again, they could suffer a broken hip or a broken knee or a cracked shoulder or whatever. That fall risk should be documented, and there are ICD-10 codes that you would document in the patient chart for a history of falling and for being a fall risk. And if you want to know what those codes are, please contact me and I'll be more than happy to let you know what those codes are. There's two different codes. One is for a history of falling, and that's a Z code, and then the other one is a fall risk, and that is an R code. And so, so be aware that you really want to set your treatment plans up and set your histories up to address possible reasons why this patient may become a candidate for these amniotic allograft injections. Now, if you can't prove 90 days of traditional therapy, do not do the allograft injection until you have completed that traditional treatment and you can document that it has not completely helped the patient resolve their condition or the pain that they are in. Okay, so this is just kind of a sample case review. If you were sending in documentation for prior authorization of these services, this would be kind of what you would want to see in a sample case review, with the age of the patient, what they're coming in for, what the aggravating factors are, the modifying factors, the fact that this patient is an active runner, that that lends to, we want to make sure that this patient can recover to that level to where they can get back to their activities of daily living. I would recommend that you always do some type of an outcome, use some type of an outcome assessment tool. In this case, the KOOS knee survey. The patient reports 40.5% disability with normal ADLs, activities of daily living. What is the patient doing to, this is the first qualification, use of NSAIDs. Patient uses ibuprofen and ice as needed. Orthopedic tests, whatever the testing reveals. An X-ray radiology is a big factor in establishing medical necessity. So I would always recommend that radiology be done, either X-ray or MRI. And then you would grade that, that knee condition. You would also then talk about what you did over the past 90 days. They received a series of high hyaluronic acid injections, physical therapy, and knee bracing. And on this case review, I would add from these dates to these dates. So you know that it was at least 90 days. Discharge exam reported increased range of motion. The knee survey reported 19.6 disability, which is good. So the patient, when they first came in, the conservative treatment was 40.5% disability on the KOOS survey. Now it's 19.6 post-treatment. However, patient returns with strenuous activity. So now they're running again. All right. So now they're a runner. They've gone back to running. They returned for stem cell recruitment injection because he did not reach MMI and would like to return to running. The survey reported a 47% disability with running. And so now we have established a case for medical necessity and for pre-approval of these injections. You definitely would like to have an imaging or imaging study, a picture or an imaging report along with the pre-cert packet that you send in to the insurance company. And I did want to show you this website because I always get questions about, well, where do you get these tests? There's a wonderful website called orthopedicscore.com. This provides a variety of patient and clinician assessment tools. They're free. And so you log into orthopedicscore.com. This is the home page. I'm just showing you a screenshot of it. And you'll see that the first one is the KOOS knee injury and osteoarthritis outcome. So if you were to take your mouse and click on that link to KOOS, where it would take you is to an online form that the patient can fill out on an iPad or on a computer, and then you can create a PDF of that and have that placed in the patient chart. And it actually does the scoring for you. So you have the clinician's name, you put your clinic name in there and the patient's name, and so you have a really nice looking report that you can submit for the medical necessity. Now, for prior authorization, as always, you know, our government payers don't provide prior authorization, so you're not going to be able to get prior auth from Medicare. You might be able to get prior auth from VA if you submit the records and get approval for it, but TRICARE, you're just not going to get prior auth. And so you want to make sure that the patient has active coverage, though, with the medical, you know, with Medicare or a Medicare Advantage plan. Now, be careful, because a lot of patients are moving towards these Medicare Advantage plans, and what we're finding is that if you don't recognize that insurance card that they're giving you as a Medicare Advantage plan, and it turns out that it's a Medicare Advantage HMO plan and there are no benefits, then you may have just done a $3,000 or $4,000 procedure and not get any payment on it. And so, and you would have to write that off. So this is you know, very, very important that you verify eligibility on the patient, not just pre-authorization, but eligibility itself. Does the patient even have coverage under this particular plan? Now, for your commercial payers, the regenerative products are unique in that they're not covered plan by plan, so they're covered patient by patient. And that's why it's very important when we do these for our clients, we will absolutely verify this patient's plan carefully in advance, and we'll want to do a pre-certification or pre-authorization of these services and gather up all the documentation and so on and so forth. So what are the steps that you need to take to obtain prior authorization? So the first thing you're going to want to do is call the payer and verify active coverage. Does the patient have insurance? Is their insurance in force? Is it active? Ask the payer if there are any written policies for amniotic allograft injections. They'll probably say no, but if they do, you know, we are seeing that some payers are beginning to develop some documentation for this. Find out where you can get those policies, okay? Ask the insurance company for the procedure on how to submit for pre-authorization or pre-certification for the amniotic allograft injections. And then what you do is, based on what the insurance company tells you, submit those records with a letter of medical necessity to the payer. Now, if you're unable to pre-cert, you're going to want to get an ABN from the patient and secure a guaranteed form of payment so that you can at least cover the cost of the amniotic product. And make sure you also add these procedure codes to your discount medical plan organization. So if you're using patient options or ChiroHealth USA or something like that for your self-pay patients, and you're going to give a cash rate for these services, make sure you add those to your DMPO. So in the event the prior auth is denied, you can arrange to have these services done with the patient paying cash for them. Or if you can't obtain prior auth and you do these stem cell, these recruitment letters for medical necessity for the amniotic allograft injections, you would want to, you know, be able to charge your patient if those are denied when they are billed out. So this is just a sample letter of a, for a clinic that, that we've had access to. It's a recruitment letter of medical necessity. It says stem cell recruitment, but this is for any kind of stem cell products. Now, I do want to advise you that if you are talking to your patients about these amniotic allograft injections, these are cryopreserved, and the stem cells are destroyed by cryo or heat. And so there are no active stem cells in these products. This is why they can be paid, because they do not have any active stem cells. So please don't call these stem cell injections. They are not stem cell injections. They are amniotic allograft injections. And be sure to call it the correct thing, okay? And so this is just an example of a letter of medical necessity. We can provide you with copies of these if necessary, and we can customize it to your own particular practice. This is a sample of an ABN form for commercial payers. You can use this, and we actually have this in a Word document, so we can send this to you. At the top of the form, you can customize it with your clinic name, address, city, state, zip, and then you can pre-populate the codes that you are wanting to give patient advance notice of non-coverage on. So this particular one is for the amniotic allograft injection and for the Palingen, and it has the estimated cash costs. Okay, so obviously I didn't put $9,000 in there because that's not what your cash fee typically would be. And we let the patient know before we render the service that the insurance company may not pay for this procedure, deeming it experimental or investigational. And if the insurance company does not pay, the patient would be financially liable, and they need to make a choice as to whether they want these services or no, they don't want the services. They don't want the services billed to their insurance, so they'll just pay the cash rate, or they don't want to have the services performed, and then the patient signs and dates this. You would give this to the patient and keep a copy in file for the patient. Now, if the patient wants the services, but you cannot obtain a pre-cert, then you should also obtain some type of a guaranteed form of payment, such as a credit card on file, debit card on file, or e-check, to be able to balance bill the patient if the services are not paid, or you have the patient prepay for the services. This is under the commercial plans. Now, we can't do that with Medicare. With Medicare, we have the patient sign an ABN form. And so this is an example of what the Medicare ABN form looks like. And again, I have this form in a Word document, so I can send it to you and you can customize it with the name of your practice at the top of the form. And if you are a participating or even non-participating provider with Medicare, you would have the patient sign an ABN form and have them choose option 1, which is yes, we'll bill Medicare, and see if Medicare will cover it. Option 2 is no, I'll just pay cash for these services, and option 3 is I don't want the services. So it's the exact same options as the commercial payer ABN, but this one is for your Medicare patients. If you're a biller of if you're a billing client of ours, and I know a lot of our billing clients are on this this webinar today, we will help you develop these ABN forms, and we will help you and we'll discuss with you the assistance that we can give you for the pre-cert of these services. And the last question that I get a lot about these services is whether these types of injections can be performed by a nurse practitioner or a physician assistant. And really that is a state-by-state determination. It has to do with the scope of practice, limitations or freedoms that a nurse practitioner or a PA might have in their state. This is a wonderful website to help you determine whether these can be done by your nurse practitioner or PA. and it's called scopeofpracticepolicy.org. All you have to do, this is the homepage. You can click on the state that you practice in. And so, for example, I clicked on the state of Florida and just took a screenshot of this and clicked the down arrow for nurse practitioners. It states that nurse practitioners may practice autonomously in primary care settings. A nurse practitioner may prescribe any drug and schedules 2 through 4 controlled substance if they are practicing autonomously. And so nurse practitioners are also recognized in state policy as primary care providers, so on and so forth. So you can look up, nurse practitioners. There's a little way down the list here. You have physician assistants and behavioral health providers. So you have this scopeofpracticepolicy.org that can help you with discovering whether your nurse practitioner or mid-level provider can perform these amniotic allograft injections. So that concludes our webinar. Again, this was just a basic introduction into these types of injections. If billing for amniotic allograft injections interests you and you want to delve more deeply into this, call us, Gold Star Medical, at 866-942-5655. That's our corporate number. You can email me for any assistance or advice with prior authorization, assistance with documentation reviews and letters of medical necessity. We can help you with the billing and the filing of the claims for all the medical and chiropractic procedures in your office. And we can also help you with your ABN forms. So, we hope that this was a informative webinar for you, that you've learned something, that you're thinking already about patients in your practice that you may be able to offer these services to. Some of you may be listening in and you're just a chiropractic office and you do not have a medically integrated practice, but you're thinking about medically integrating your practice. A lot of the doctors that we work with are clients of Advanced Medical Integration. They're a wonderful organization to help you medically integrate your practices. So, I would, by all means, feel free to call on them for more information on how to medically integrate your practice and, and be able to do some of these types of injections. Okay, well, that ends our webinar. I do have a couple of hand raises. So let me pull the chat box up, and it states, how long does it, I've got one person who asked, how long does it take to hear back from a pre-cert or pre-approval? Honestly, it depends on the payer. It can take, I usually tell the providers to expect at least a week, if not more. There are a few payers that we have access to the provider portals where we can upload through the provider portal the request for pre-certification. So, but I think if you think about it in terms of how long does it take to get payment from the insurance company, anywhere from 2 to 4 weeks, I would say is, 4 weeks is probably going to be on the long side, but hopefully within a week to 2, you would know if it's pre-certed. And remember, because your documentation is going to be different for every patient, don't assume that if you get one knee case pre-certed that the next one is going to be pre-certed, because your documentation may not support that second knee case. So don't feel like, oh, I'm just going to do a few pre-certs and see if they're paid and then I'll start billing it. You want to pre-cert on a case-by-case basis, okay? And I've, okay, we have another question. If a patient receives temporary relief from hyaluronic acid, but of course the pain returns, how do we address this in medical necessity on pre-cert? Great question. So what you would do is, if the patient is returning after a course of treatment, then you would make notation of that course of treatment. you would make notation. If your office did the HA injections, then you can make notation to the prior notes on the HA injections. You can make notation of in the return visit from the patient, you can notate that the patient did have a you know, a success with the HA injections, but now has returned after and especially if they return prior to the 6 months, because we know that the HA injections are payable after 6 months, meaning that medical necessity can be reestablished for HA injections after a series has been done and at least 6 months has elapsed. But if you have a patient that's had these injections and they're coming back 3 months later saying, I still have pain, then this is probably a good candidate for these allograft injections. And so that is how you would want to document it. Document the prior treatments, document when they happened, document that the patient did not meet, you know, they're coming back for another series of injections, but they haven't made it to the 6 month time frame. And so now we're going to be looking at these at these allograft injections instead. Okay, it says, do most offices get pre-cert, pre-approval before scheduling and doing the service? And the answer is absolutely, because these products have a very short shelf life, about 3 days, I think. So you have to coordinate the purchase of the allograft product with, and make sure that you receive that product within a few days of that, you know, probably within, if you can do it within 24 hours and get that patient in within 24 hours to have that injection done, because these, again, these products have a very short shelf life. So, yeah. And then I had another question. Will you be sharing a recording and your slides? Absolutely. I'm going to convert this recording as soon as we are done, and I'll have it posted on my website. I also believe that AMI is going to rebroadcast this recording next week for other AMI clients who are not clients of Gold Star Medical. And I will send out a mass email to all of my clients with the handouts. So you will all receive copies of the handouts, absolutely. Let me see if I have any other questions. I don't think so. I think we had one person. Okay, here's a few others. These were in the Q&A. Will Regen be covered out of network? Can you still get a pre-auth if provider is out of network? Good question. Some payers will not cover out of network. Some will. Some will allow pre-auth and some won't. This is going to be on a case-by-case basis. Listed price of Palingen, do we buy it through you? Absolutely not. I'm not a dealer. So you would have to go directly through InnovaFlow to purchase that product. Must treatment be 90 consecutive days? Can it be 2 different types of consecutive care? Example, 2 months of PT and 1 month of bracing. And the answer is on the treatment, they're not super specific on 90 consecutive days, but it should be within a fairly short period of time from the time, you know, it should be like the 90 days prior, and now the patient is coming back after, you know, they've had 90 days of treatment, and either that 90 days of treatment has not resolved their problem, or they've had 90 days of treatment, it resolved the problem, but now the patient is coming back quite soon after that treatment, and they have had an exacerbation of that condition, okay? And yes, it can be 2 different types of conservative care, 2 months of PT and 1 month of bracing would qualify, okay? I think that is it. Let me just make sure I don't have anything else that has come in the chat box. So exciting for regenerative medicine revolution. Such a great move in the right direction. You guys are welcome. I'm very excited about this. This is like, you know, I've been doing this for on 38 years now. And so It's not often that I get to delve into something new and something different. We're all kind of learning together, so we do ask for your patience and grace, but I will tell you that we will do everything we possibly can. And that's why I say, I would not feel comfortable if I was your biller, just, and I've had a couple of clients who have said, hey, here are some charges, I want you to bill them. And I'm like, no, we're not going to do that. And so what I've done with those clients is I've sent back the criteria, and then I get an email back saying, well, I think it's a little more complicated than it appears. And I'm like, yeah, it is. And so we have to make sure that we're doing this right. You do also need to understand that this from the Medicare standpoint, the time frame for these injections being approved may be coming to an end at the end of the year. And so one of the things that we really want to do is we want Medicare to see the effectiveness of these treatments. We don't want Medicare to take it back. And so they've opened this up for treatment of the knees, of the osteoarthritis of the knees. And we really want Medicare to see the effectiveness of it from the patient standpoint. And so, hopefully some of you will have billing to do. And again, I will be talking to you guys probably what I'm going to be doing with this. And I'll be honest with you, this isn't going to be, like I know for some of you, and I'm just going to stop the recording here because we really don't need to do the pause recording.